Good morning to all. Now we invite Alok Thakkar. He doesn't need any introduction. He is a professor of otolaryngology and head and neck surgery, All India Institute of Medical Science, New Delhi. Positions held: President, Neuro-Otological and Equilibrium Society of India, Treasurer, Hull-Based Surgery Society of India, Honorary Secretary, Foundation for Head and Neck Oncology, Honorary Secretary, Neuro-Otological and Equilibrium Society of India, Honorary Vice President, Otolaryngology Research Society of AIMS, ORSA, President-elect, Neuro-Otological Equilibrium Society of India, Research Impact. Authored as chapter in Scott Brown's Textbook of Otolaryngology, 7th edition. Cited by international publications on 326 occasions. Welcome, sir, and you are invited for this lecture. Please, sir.
Thank you, sir. So, greetings from Delhi. I come from the All India Institute of Medical Sciences, and what we have here is our original campus in Delhi and our new cancer center on the edges of Delhi, which is the National Cancer Institute. I speak to you about oral cancers and what we have learned over the last few years. Of course, it's not me alone. Oncology is not something we work on alone. There are so many of us, both from our specialty and from radiation and medical oncology and pathology and every other related pathology, radiology. And certainly we have a fair number of head and neck surgeons from our institution who have come in now offer the services in this city. So happy to be here. Moving forward, we know about oral cancer now being the commonest cancer in males in India. We also know that oral cancer is today the commonest cause of cancer-related mortality in young males. What I'm going to be presenting here is a little bit that we have gleaned from our recent audits with regard to oral cancer over the past few years, and these two specific papers which is published in. So one is with regard to our survival outcomes and risk factors with primary surgery, it was published in the Diagnoscope, and the other one more interesting is about what happens with the tumor-host interface in these situations. So the good thing about these, to put things in perspective, this is a cohort of patients who have all been treated with the current standard of care, which is by primary surgery and subsequent adjuvant therapy as indications listed here, with the standard indications for today. They have all been staged at 58 AJCC TNM classification, so it's very much relevant to contemporary practice. And the median follow-up on these patients is about 3 years. So what have we done? Of course, there are many kinds of oral cancer, we know that. There is certainly some thought as to whether all of them need to be clubbed together. In our own data set, and this may be different from what you see in this part of the country, but in our own data set, tongue and throat of mouth is about 1/3 of what we see, and the other kind of cancer, which is the gingival ductal cancer, is about 2/3 of what we see. We do believe that there are differences between these two groupings, and perhaps they should be taken into account when we plan therapy. In terms of results, just to put things in perspective, there is some good news that early cancers are now getting commoner. 1/3 of our patients come with early cancer, stage 1 and stage 2, and do fairly well in terms of outcomes. So we have an overall survival at 3 years at 87% and disease-free survival at about 80%. Obviously, late cancers don't do so well. 3 years overall survival at 57% and disease-free survival at 47%. By 5 years, it comes down to about 25%. We do feel, and this data doesn't quite prove it conclusively, but it does seem that tongue cancers do relatively poorly by about 10% compared to cancers of the gingival buccal sulcus, so the gingival buccal grouping. So what you see is the red group 1 cancers, tongue, throat and mouth cancers that seem to do a little bit poorly. Sometimes this is just on the edge of statistical significance and sometimes it's not. But if you had a larger data set, I suspect this might come through. Our cancers, our patients with oral cancer are much younger than what is reported from the developed world. Significantly younger. So if you look at the data from the US, the median age is 63 years, but we are at This is held out by other publications from our country, probably reflective of the high exposure we get to tobacco at fairly early ages. And unfortunately, young age also means a poor prognosis. Certainly in our data set, it seems that if you are less than 40, you have twice as high a chance of recurrence. Also, end stage, and this is well thought out, as a higher chance of recurrence, 3.5 times higher chance of recurrence. Skin invasion has a higher chance of recurrence. Surprisingly, C-stage doesn't impact as much, and bone invasion doesn't impact as much. Bone invasion has always been a sign of T4, and of course impacting on prognosis. But in our data set, and even from a previous data set that came out from the Tata Memorial Hospital, it does seem that when you treat these patients with surgery, followed by radiation, then certainly much of the poor effects of radiation are countered by this therapeutic approach. The poor effects of bone invasion are countered by this therapeutic approach. Unfortunately, a lot of people are failing, and we see that there, and they're failing very early. So 43% of patients have failed by 11 months itself. So who failed? Patients who fail very early. A fair number of this is second primaries, which you see down there. But what is really of concern is that a lot of patients are failing as primary site itself, which really shouldn't be happening if you have effective treatment. So a fair number of patients are failing at the primary site itself and failing fairly early. So obviously surgery followed by adjuvant therapy is not quite working for them. And also what came out in this audit, and it was against conventional thought, was that if they would take the maxillary artery or maybe the external carotid, the high external carotid, to cut off the arterial supply to these lesions, and the resection would start, of course, by getting the medial head from the styloid to the digastric and getting the mandible out and moving along the retromoral trigon, posterior wall of maxilla, pterygoid plate. This is the greater lingual sphenoid, which you can see the periosteum being stripped off, the foramen ovale somewhere there, spinal cord somewhere there, and the receptor for the condyloid process, the PM joint there. So big dissection, including looking at periosteal or subperiosteal levels to include the whole space. And even though a free fibula graft is the ideal thing to do, it's often done. It is not quite an essential thing, and you can do it quite well with procorenal flaps too. This is a patient of a few days ago. Yeah. Similarly for tongue, the Italian group has shown not an head-to-head control trial, but certainly with a retrospective control that can anticipate an improvement of 20% in local control and survival just by moving on to the concept of compartmental resection. And this again is going to be standard to us for T2 to T4 regions of the tongue. There's a lot of conceptual other specialities.
A lot of things and the materials and statistics are too good, and really hats off to you there. And few questions from my side. And from your experience, whether this free flap is ideal or this PMM flap is ideal?
So we tend to use free flaps very judiciously. I know they are what we use and are used, but frankly, we use them fairly judiciously, and the reason is we want to retain competency, we want the trainees to retain competency, and frankly, I think we get fairly good results with them, at least with tongue cancers. With gingivobuccal cancers, when you remove the mandible, there is certainly something to be said for having precise fibula in place, because it aids mastication. It keeps your fibula in place, and you can use the contralateral teeth better. But in situations wherein you have poor prognostic situations, as I said, our 5-year survival rate till recently is in the range of 35% for advanced cancers. You have to be also careful of allocating resources, and certainly in our situation wherein we have long waiting lists, we would very often focus on patients who have really poor prognosis, so we will not have taken another patient in then expend resources on free flaps. In our situation, our free flap rate is about 20%, while I know that there are many institutions wherein the free flap rate would be about 80%. But nevertheless, I see we give our patients good service and our focus stays to be on oncology. So we have registered with three labs. You can certainly do very well with local regional labs. You can do better with free labs in some situations, but not in all the situations that it's talked about.
Thank you, sir.
Thank you very much for your wonderful presentation, sir.
Thank you.
We have people sitting at the peripheral areas,
Yeah.
like Rajawale in the southern part of Tamil Nadu. Even in a small clinic, we have done a heavy cross-sectory with neck dissection. But your presentation has thrown more light on us regarding the flaps and all. Thank you very much. Because we have not done flap things because we don't have any process and facilities. Suppose the margin has it just has small amount of malignancy. Patient may need post of radiation and other things. So as we don't have any frozen and other, we have done only intrasectory and neck dissection. Number two, I want to say is thanks for the organizing committee for 2 years as the chairperson for your presentation. And thank you very much once again. Thank you.
Thank you, sir.